Bismillah ar-Rahman ar-Rahim. In this video, we are going to resume this nice presentation from Qasr al-Aini about the ophthalmology slides, and we are going to navigate through the trauma chapter. This drawing is a very nice drawing for the effect of trauma on the anterior segment of the eye. And you could face this question in exam, for example, give an account on effect of trauma on the anterior segment or the back of the eye or the whole eye. So in this presentation, we can see some lacerated wounds in the eye, like this horizontal laceration in the skin, and this laceration including the tear duct. And in this laceration, we have to sort or to take sutures in the lid margin, as well as fixation of the torn tear duct, either at the same set for the tear duct or as soon as possible. And as we can see in this laceration, you have to beware of retained foreign bodies. So you might ask for X-ray or CT orbit, and it's not advisable to do MRI orbit because this foreign body might be metallic, and because of the magnetic field in the MRI orbit, you might cause some more harm to the eye. You have to evert the upper lid to look at foreign bodies, which might be retained in the sulcus subtersalis. And in the subconjunctival hemorrhage, we are going to talk about subconjunctival hemorrhage in some slides. Hyphema, iridodialysis. We talked about iridodialysis in previous videos. And the D-shaped pupil, foreign bodies or ulcers or abrasion in the cornea, we're going to talk about that. And corneal lacerations and prolapse of intraocular structures. And you have to examine the eye movement as well, because there might be some limited ocular motility, either of paralytic or restrictive cause. So let's take the first slide. Sorry, I'll switch off the Wi-Fi. Okay, let's take the first slide. This is a slide of the cornea with a lesion, a green lesion in the center of the cornea stained with fluorescein, and this lesion is either corneal abrasion or corneal ulcer. If it's just superficial, not including the stroma, it's an abrasion. If the lesion is deep and including the stroma, it's a corneal ulcer. And in case of corneal ulcer with deep infiltration, we have to take to do corneal scraping and send it to lab because of possible infection. So we have to do corneal scraping for gram staining and culture and sensitivity. And the treatment of this abrasion is topical antibiotics, topical lubricant drops, and we have to search for possible secondary anterior uveitis, so have to examine the anterior chamber under slit lamp, searching for anterior chamber activity like cells and flare. Again, corneal abrasion stained with fluorescein, this green color, and the photo is under the blue filter in slit lamp, the same treatment. And the symptoms here are lacrimation, photophobia, and blepharospasm. Some people might advise to cover the eye for a period of 4 to 6 hours to improve healing of the corneal epithelium and to decrease the severe pain because the cornea is very sensitive. Corneal foreign body should be removed under topical anesthesia, and it can be removed by a needle or a burr. And again, after removal, the corneal foreign body leaves an abrasion, so we have to treat with topical antibiotics and topical lubricant drops. We might cover the eye as well, to patch the eye. If you are considering to patch the eye in these situations, you have to make sure that there is no discharge. Because if there is discharge, which means an infection, it's not advisable to cover the eye. You have to make good drainage for this discharge. And in case of this corneal foreign body, you have to search for other foreign bodies. I mean, you have to search in the corneal, in the conjunctival fornix, and to evert the leads to see if there is retained foreign body in sulcus subtorsalis, like this one. And you have to search for possible intraocular foreign bodies as well. This is a photo of peri-orbital hematoma, which is called raccoon eye or panda eye, like a panda or raccoon, and a subconjunctival hemorrhage in the right eye as well. So the most common cause of this is trauma, and in case of trauma, in history of trauma, you have to fully examine the eye systematically. You have to start with the vision, the pupil, the intraocular pressure, the ocular motility, the pupil reactivity, and you have to meticulously examine the eye, the cornea, the anterior segment, the posterior segment, to search for the possible effect of trauma. Because this is a superficial hemorrhage, but there might be some deep hemorrhages. There might, peripulpar or retropulpar hematoma. There might be fracture in the orbit, which might necessitate surgical intervention. For example, in this photo, you can see subconjunctival hemorrhage, extensive subconjunctival hemorrhage. And in this photo, we cannot see the posterior part of the hemorrhage. I mean, the extent of the hemorrhage is not visible. In this situation, you have to suspect fractured base of the skull, especially if there is a major trauma. So in a case of subconjunctival hemorrhage, for example, you have to ask the patient some questions. The first question is, of course, about trauma. And the second question, if this patient is hypertensive or not, and you have to measure the blood pressure for this patient. Sometimes this might happen spontaneously, but you have to rule out any other ocular hemorrhages. So you have to examine the anterior part and posterior part of the eye. Subconjunctival hemorrhage itself is not for treatment, so it will wear off in days or weeks, but you have to search for the cause, like trauma, uncontrolled hypertension, bleeding profile, and you have to ask the patient about the valsalva, like lifting heavy weight, like forceful cough or sneeze, and you have to search for other sites of hemorrhage inside the eye, and you have to exclude the fracture base of the skull if this is a major trauma. In this photo, you can see extensive subconjunctival hemorrhage with extensive conjunctival swelling, which is called chemosis. The conjunctiva is chemotic, swollen, extensive subconjunctival hemorrhage, and this might happen after trauma or after anesthesia, like peripulpar or retropulpar anesthesia, and you have to deal with this situation like we dealt with the previous ones. I mean, to systematically examine the eye, starting from vision, pressure, pupil, motility, anterior segment, and posterior segment. In case of this extensive hemorrhage, this might cause compression over the eye and elevating the intraocular pressure to very high numbers, and this might harm the optic nerve. So you have to decrease the intraocular pressure by performing some gentle pressure over the eye to stop the bleeding, by performing lateral canthotomy, and by giving systemic aqueous suppressants like acetazolamide or mannitol. Again, subconjunctival hemorrhage, but in this photo we can see the posterior border of the subconjunctival hemorrhage, which rule out a fractured base of the skull, and we can search for other causes like trauma, uncontrolled hypertension, bleeding profile, and so on. In this photo, we can see the red color now inside the eye. It's called intracameral, which means in the anterior chamber. And this bleeding is called hyphema. when you see hyphema, you have to search for two harmful effects of hyphema. Number one is the intraocular pressure, and number two is the corneal staining. So in this case, with history, we will ask the patient about history of trauma, history of surgery, intraocular surgery, history of uncontrolled blood thinning intake, or some disease like sickle cell disease. But we have to measure the intraocular pressure, and we have to look at the cornea through the slit lamp to see if there is a corneal staining or not. So, and we have to measure the hyphema as well for follow-up. Treatment of hyphema is mainly rest in semi-sitting position for the blood to settle down, and it's going to be absorbed with time, within days. But if we found that the intraocular pressure is high, and there are various guidelines for surgical intervention. So if the intraocular pressure is high, we have to take aqueous suppressants. And the topical aqueous suppressant of choice is mainly the beta blockers. So we don't usually use other aqueous suppressants like prostaglandin, because prostaglandin is an inflammatory mediator, and in hyphema there is some intraocular inflammation, so prostaglandins are not preferable. And if this patient is a child, so we don't use alpha-2 agonists because they cross the blood-brain barrier. Carbonic anhydrase inhibitors topically and systemically could be used, but they are contraindicated in sickle cell disease because they might cause sickle cell attack or crisis. And for sure, we do not use miotics like pilocarpine because they disturb the blood aqueous barrier. We have to use cycloplegics like cyclopentolate or atropine to stabilize the blood aqueous barrier and to prevent synecdoche, as in hyphema, posterior synecdoche might happen. So if the intraocular pressure is high, is elevated, we have to use topical aqueous suppressants, beta blockers, and topical cycloplegics like cyclopentolate or atropine. Using of topical steroids is debatable, but some ophthalmologists prefer to prescribe topical steroids as well to decrease the inflammation and blood clot formation. So treatment is mainly rest in semi-sitting position and to decrease the intraocular pressure, if any. What are the indications of surgical intervention? As I mentioned, there are many or various guidelines, but you have to take one guideline and to put it in your mind. So if the intraocular pressure is more than 25 millimeter mercury for 5 days, you have to surgically interfere. And if the intraocular pressure is higher than 60 millimeter mercury for 2 days, you have to surgically interfere to evacuate the blood clot. If there is a total hyphema, the blood is filling the whole anterior chamber, you have to surgically interfere. And if there is a start of corneal staining, you have to surgically evacuate this hyphema. Again, the effect of trauma on the lens, cataract, and characteristic shape, which is rosette-shaped cataract, and the Vusius ring, this impression of the physiological or the narrow pupil over the anterior capsule, which is the Vusius ring. So what is the importance of this Vusius ring? If you saw a Vusius ring, or if you saw a rosette-shaped cataract, as we mentioned when we were talking about cataract extraction, you are preparing this patient for a cataract surgery. So if you saw a rosette-shaped cataract, or if you saw a Vusius ring, for example, you have to take care that this patient might have trauma before, even if the patient didn't tell you. Because of the possible effects of trauma on the eye, like high intraocular pressure from this previous trauma, the subluxation, the possible subluxation of the lens. So if you saw these signs, you have to take care that this patient might have trauma before, with the dangerous effect of trauma on the surgery. This photo is very blurred and I'm not sure. This is cataract. This might be some posterior synecdoche, but this is very blurred photo, so I have no definite conclusion for this photo. And the last photo is subconjunctival hemorrhage, and as we can see here, there is a full thickness corneal laceration with prolapse of with iris prolapse. And this is an emergency situation. We have to close this corneal laceration, and we have to put the iris back in place. And it's preferable to do that in the first 6 hours of trauma, because if the patient presented to you later than 6 hours, you will find necrotic tissue over the iris, and it's contraindicated to reposition this necrotic tissue inside the eye, so you are going to cut the necrotic tissue out. So the treatment for this, this is called the ruptured globe, where you find full thickness laceration of the cornea, and this patient is in danger of developing endophthalmitis. So you have to take this patient to the operating theater to do the surgery under general anesthesia, and you will repair the cornea. The first is to cut any necrotic tissue here, to reposition the iris, and to take 10-0 nylon suture in the cornea and to reform the anterior chamber. Of course, before doing that, you are going to thoroughly examine the eye, starting as usual from vision. You might not be able to check the intraocular pressure, but we can do that through some instrument like the eye care, the rebound tonometry. And you have to dilate the pupil. As we can see here, there is early synecdoche, so we have to dilate the pupil and to check the back of the eye to see if there is any possible damage to the retina, the choroid, the sclera. And during surgery, we are going to explore the limbus here. So we are going to do peritomy to cut the conjunctiva at the limbus here, because this wound might be extended into the sclera. So to avoid missing some possible scleral laceration, you have to do perimetry and to explore the sclera here and take sutures if needed. So that was the last slide in the trauma chapter, and I'll see you next time in the extraocular tissues. I tried in this video to talk in English, because I receive some requests from some of our non-Arabic speaking colleagues to talk in English in the videos, and I'm planning to do some postgraduate videos, especially in my specialty, which is glaucoma, in English. So it was a trial. I hope you find it good and as good as Franco-Arab, and see you next time. Thank you.